And I'm curious, kind of, with that first wave of kind of the first wave of reimbursement change that was managed care, how much different is that what we had today? What were the drivers for managed care that were kind of promoting that consolidation?
Well, the first wave of managed care was all about cost containment. I mean, there was not a lot of emphasis on outcomes, on quality of care. It was really, what does it cost? And that has changed. I mean, we'll talk, I'm sure, at some point about value-based care in this hour and a half that we have. But the other piece that I just kind of find interesting is that health systems are doing exactly what the practice management companies did back then. So your healthcare systems now have realized that the hospital is not the nexus of all that they do, that they are, in fact, distributive healthcare networks that happen to operate hospitals, and the hospital is becoming less of a driver of the bottom line. And in fact, we're seeing a huge outmigration of services from the hospital to the health system's ambulatory footprint to lower cost at the same outcome.
But the key has been diversification, and I know you in your practice career and I in my practice career both had the experiences where the smart people who were running the practice said, I don't know how long this chemotherapy is going to go on. You can only treat so many patients, and there's a ceiling on growth when chemotherapy is your sole service line. We need to think about radiation. We need to think about imaging. Maybe we should hire a surgeon. All those other services, under the term of diversification, facilitated practice growth and practice success, and in fact became an attractive care delivery partner for managed care, right? Because they can negotiate a kind of an integrated contract with the provider. That was U.S. Oncology viewed that as their the game plan all along. After the negotiating around the drug thing went away, this was still going to be something that we could offer to our practices in our network in terms of dealing with other people.
I think you could say that not just from the independent practice, but also from the hospital side as well. The add-on services were also a big driver.
So Mark, is the managed care of the 90s, how is it different from value-based care of today? If this is another wave that is a driver to much of what we're seeing with consolidation, how is it different?
Well, I think, as I alluded to just a couple minutes ago, we're beginning to start to understand how we're measuring quality, and we have a long way to go. But back in the managed care 90s, it was just saving money, right? I mean, that was what it was all about. Denial of service. I mean, that was something we as providers all experienced, and you can't do this, you can't do that. In true value-based care, that's not part of the equation. Yes, you want to manage costs, but you also want to make sure that you're providing a quality outcome. And if you drive down costs, but you make the outcome worse, it's not considered a success. So I think that's a big difference now.
Well, the other thing that's absolutely true is that health insurance companies do not want to be claims payment companies. There's a limited degree of profitability that you can get through adjudicating and paying claims. There's a certain administrative fee that you can generate on that kind of a service.
Medical loss ratio we're referring to?
It is.
Right.
It is, right? So, and now we have a law that limits how profitable a health plan can be. So,
you said MLR 15%?
That's it, right? So you can grow either by getting more members, which if we're going to talk about that in a second, or you can grow by diversifying your services and finding other ways to make money. And that's what we're seeing, actually, interestingly, in the payer world right now. That's how I look at it.